work at John F. Kennedy Medical Center as a gynecology and also as a gynecologist and also as an obstetrician.
Okay.
So, as a gynecologist, we see women with problems with women cancer, women that come bleeding. Those women are referred to us for us to see and manage. So we actually manage those cancer that affect the women reproductive tract.
Okay.
Cervical cancer is number one. That's the major cancer that causes death to our women. For vaginal cancer,
Okay.
vulvar cancer,
Okay.
ovarian cancer, endometrial cancer, and the gestational trophoblastic.
Okay, thank you.
neoplasia.
Okay. Mrs. Doe.
So
Let's
thank
hear from
you.
you a little bit on your role at the Ministry of Health as well.
So thank you. Actually, I serve as the supplemental immunization coordinator. That means I'm responsible for all mass campaigns. So the mass campaign is not only restricted to HPV. Sometimes we have measles campaign, we have yellow fever campaign, we have COVID campaign, and everything that has to do with mass vaccination. That's the role I play. So I coordinate that aspect with the EPR in the Ministry of Health.
Okay. Mr. Nire.
Thank you. So, as you rightly stated from the beginning, I work as the coordinator for vaccine safety surveillance for Ministry of Health. And the task is just very simple. Vaccines are like any medicinal product that we take into our bodies. And by reason of taking those in the system of a human being, we need to monitor. That is the aspect of the safety that comes in. Vaccines are introduced into our bodies not to cause harm. However, sometimes reaction can occur based on the biological makeup of the person. And these are the things we monitor to document as a country. How far is the safety profile of vaccine we use in Liberia? And we'll do that in collaboration with partners in the country.
So the way you come in when it comes to tracking the reactions.
Exactly. So especially we're going for a mass vaccination campaign, and that is an injectable. We need to be very careful that the skills are good and the personnel are well trained so that the vaccines are given according to instruction guidelines by reason of the route, the site, and the dose of the vaccine to be administered.
Okay. Well, we're talking about the multi-age cohort vaccination campaign, right? But and when we talk about this campaign, the HPV campaign, it linked a little bit to cervical cancer. So before we deepen our discussion to the vaccine and all of that, let's firstly establish the cervical cancer and that of the HPV, what it is, what the difference between them. What is cervical cancer? How is it different from HPV? Around that.
I think I would prefer that Smith goes first. Let him set the clinical basis, and then we'll come on to the preventive or the public health measures around the disease or the condition.
Okay, thank you, Mr. Nire. So, cervix is the anatomical structure that is at the entry of the womb, the uterus. So that cervix can be infected with HPV, with any infection. And one of those infections that the cervix can be infected is the human papillomavirus, the HPV. And that HPV virus, when it enters the cervix, it stays there or it is clear. Two things happen. So if the HPV vaccine clears out, then the cervix becomes healthy again. If the HPV vaccine gets integrated with the cervix, the cervical mucus, with the membrane of the cervix, it stays there, and then it starts to replicate, multiply, and then that can lead to something we call precancerous lesion. Then, if nothing is done, that woman, if doesn't go to the hospital for check, or sometimes she goes to the hospital and says it's infection, and they didn't check or they don't screen her properly. That pre-cancerous lesion, it's not cancer yet. The HPV causes a pre-cancerous lesion. That lesion will also start to develop. And then after maybe 10 years, 15 years, that woman can develop cervical cancer. And when it reaches cervical cancer now, it becomes a challenge. So that's the difference. So HPV is the major culprit of cervical cancer. HPV is that virus that causes cervical cancer. And the good thing about it, it can be, you can vaccinate young girls with the HPV vaccine that will prevent that HPV from integrating to the cervix to cause cervical cancer. So it can actually be eliminated.
So let's understand. Okay, you want to come in, Mrs. Smith?
Yeah, so let me,
Not Smith, Mrs. Dole.
yes, so
Yeah.
let me add to my colleague. Actually, the HPV is a virus, like you said, it's called the human papilloma virus, and it's transmitted through sexual intercourse. So actually, during sexual intercourse, is the cervix that is exposed, and this is why the virus affects the cervix. So that's how it happens. So like you were explaining to adult, if the virus enters the female system, it interferes with the cervix and it leads to those lesions that gradually
So-
lead to cancerous condition as well.
Yeah, so you want to add it?
Yeah, just to add a
before
little.
you add it, let me
Yes,
just
thank you.
I wanted to follow on something. It's transmitted through sexual intercourse. So who carries that?
So usually the male are the carriers. But what happens in males is that it doesn't affect them. They just carry because they don't have cervix. It's the female who has the cervix. So the male is healthy and he carries the virus. But whenever there is an intercourse between the female and the male, then the female picks it up because she has cervix. So it causes that effect on the cervix. So the male will be healthy, just very rarely, because male doesn't have womb. It's a woman who has the womb. That's why we focus on ensuring that we can get to our women.
So just quickly, let me just add my delight in teaming up with Dr. Smith, and a very good link up since the Ebola outbreak over in Riverside. So welcome back. So just to add on, you heard the doctor talk about anatomical position, places and what have you, and I'm sure people in the Leeward counties are listening. Our old man then from Waterside, from Rail Light and the rest of the places are listening to us. Just to come back to all of us that will understand, the women God made them in a way. There's a special part of their body when they get pregnant, when the baby is lay down. That's why the medical people call it womb. And then the womb, it got place to enter, like the room got doors. That's what we call the cervix, the mouth of the womb. And this is where the HPV guy, being so notorious, he can go and cause a problem for our women, to embarrass their process of being able to born, and even cause infection for them, that sometimes some of them die. Later on, maybe during the discussion, you may hear some seriousness around this disease as far as it is concerning Liberia in terms of affecting women.
Is this HPV virus, is it common in our setting? Is it something on the increase?
Okay, so maybe I can take a shot on this. Well, the public health people probably will come in with data, but what we see in the clinics, the cases of cervical cancer seem to be increasing from our database. So probably that may tell us that the transmission of HPV, because like we said, HPV is the one that causes that cancer. It's also very, very, very high. And like she said, sexual intercourse is the one that is transmitted by. So most of the time, men, people who are sexually promiscuous, have multiple sexual partners, they are high risk people. So So that's it. So I mean, our attitude and our ways with sexual intercourse is something that need to be highlighted. So I think yes,
It's on
have-
increase.
yeah.
So maybe just to portray the
Yes, sir.
doctor, I think you use the right term whether the condition is on the increase. And this hinges on the surveillance system of the country, how well we are able to track the cases. And along the course of time, since we first talked about the human papillomavirus vaccination 9 years ago, we also see alongside the public health measure of the prevention, we see there are a lot of clinical intervention, like he will talk about screening later on. So as more and more of our health facilities will create the screening site, we are able to document more how much we have. But already from most data we have is they are stating to us that HPV is the most cervical cancer is the leading cause of cancer in women, and if not the leading cause of death in women as well. So it is increasing, but it's based on the intervention we are making to track the cases more and more from all across the country.
So, yes.
So even if you see the clinical data that is gathered of the total number of cases being diagnosed in Nigeria, cervical cancer stands as the leading cause of cancerous death, which means there are other cancer, but the cervical cancer serves as the leading cause of cancerous death. At the same time, the data collected, of that total number of data collected, more than 50% die as a result of cancer,
And, yeah.
as a result of lung cancer. So, of the total number of data collected, more than 50% of that number die.
So somebody listening, maybe this could be their first time to hear the term cervical cancer, and how does one know that they are carrying this virus? How does a lady be diagnosed herself, or how does she notice herself as a carrier of cervical cancer to make her way to the clinic or the nearby health facility?
Okay,
The doctor will clarify that, but one of the things we need to mention first and foremost is that most of the cases will come about without you having a sign or the symptom as a person.
Okay.
They go without symptoms, and that's the delicate part about the prevention or the control as a country or as a health system. Most of them will not show symptoms, most of them will not show sign. By the time you see them, they may be late or at a stage that might be difficult to deal with, but the doctor will weigh in more on that.
Yeah, so I think Mr. Mary has said it. Just an addition, you are not going to, most often, the virus is gotten through sexual intercourse, and most times it's the first, second, third sexual intercourse when the girl is young. And then she doesn't know, so it stays there. She's asymptomatic, like he said, no symptom, no fever, nothing. But the good thing is, the body will clear it out when the body is not compromised. Like, you know, that person eating good food, they're not sick, you understand, they're not immunosuppressed, their immune system is strong. So that's why we need to screen. That's why we are here. So you don't need to wait before you start, getting sick, probably, having discharges, having bleeding. So you come to the hospital, you screen. In fact, we are screening all of our girls, at least, above 25 years. You need to screen them. And then when you screen them, you will know that, hey, the virus is present.
At age what, if a girl child is growing up, at age what she gets, I mean, how do I term it? I mean,
She's vulnerable
yeah,
to the
okay,
condition.
fine, thank you. Vulnerable to getting this virus.
Once she starts sexual intercourse, once she starts main business, she gets vulnerable to this virus. That's why the public health people will tell you, our emphasis is on prevention, because to kill them is a serious challenge. So we need to prevent them before they start sexual intercourse. That's the main reason.
I like that word.
So if you give them the vaccine, now when they get exposed during sexual intercourse, the vaccine is going to block that process of carcinogenesis, that process of forming the cancer. So that's the reason.
So like the doctor rightly stated, what we are pushing for here, and we must be clear with our messaging, our discussion here partly is in twofold. One being the vaccination being the gold standard for prevention,
Yeah.
and then the aspect of screening that you talk about, which we could call secondary, and what other measure of prevention we are talking about. And within the primary prevention, we say vaccination stands out as number one. Alongside vaccination, we do health education, like promoting safe sex among those adolescent girls, and at the same time creating awareness on some other habits that might lead you to the terrain of cancer, like smoking. If there is smoking cessation, by greater proportion you are already preventing some other forms of cancer, not only the HPV. More to that is that, like you rightly stated, the vaccine has an age whereby when it is introduced to the girl, by the data we have in country, by our practices, our behavior, the girl should take the vaccine before becoming sexually active. So it is best before the first sexual debut, let that girl receive a vaccine. That's why WHO guideline is leading the whole world, of which Liberia is a part, that girls from 9 years old will start to take the vaccine. By that time, the people who do reproductive health, they call puberty, which is the appearance of the secondary sex organs, and they are all coming alive. You see the breast being formed, and your body is getting ready to be able to be part of the reproductive process of the world.
Okay, that's it.
So let me add to my two colleagues. So if you look at where both of them were screening, we have a time for screening. For them that are doing the screening, they are doing it from 20 years and above.
Yeah, with that screening.
They just screening. So the focus is at that time, it's possible that if you have that age at that time, it's possible that you have it. So that's why you see they are screening people who have age around 25 years and above. For us, for preventive purposes, we are not reaching that age group. We want to do that prevention before the person can get to that screening time. So that is, we would have introduced the vaccine in the system if the child start to be sexually active. So if the girl is around 9 years, it's a plus. Even if they are up to 18 years, we can also provide that prevention. So that's why we are doing. So it's a two different things. So once you pass that age, then they start to screen you that probably you have the condition. But before you reach that age, we can vaccinate you so that you don't reach the point of being screened and then the problem being diagnosed in you.
So meaning that is the reason girls from 9 years will be vaccinated?
Yes. So because in Liberia or across the world, we are aware that
Because the reason I'm asking this question, at 9 years, a girl will not be having any sense of having sex.
it's true.
Yeah.
So what we try to do is to introduce the vaccine before she reaches the age of having sex, then at least she have some level of protection.
Okay. So how many girls are expected to be screened or vaccinated across the country?
So let me just draft a little bit on the preventive aspect. So for prevention, we are preventing girls from 9 to 18 years. That's the campaign we're trying to launch now. So those girls, we are 100% sure that, or we are sure that those especially below 10 years will be people who are not sexually active. Even though it is possible that from 9 to 18 years could be having sex, but we are saying to ourselves that they are not sexually active as people who are above that age. So we want to vaccinate them with the vaccine to prevent them. So if you look at our entire cohort, it's about more than 500,000 girls that we want to vaccinate nationwide in the 15 counties. And that would be the straight launch that we'll be doing. And our activities we expect it to kick off by November 17th to the 21st. It will be 5 days activity nationwide. It will be very intensive. We want to be vaccinating the girls between age 9 and 18 years.
And this is where her job at the immunization program, the Ministry of Health, becomes very important as the coordinator for mass campaign activities. And this is just a short time interval, 17 November to 21st will be the campaign. But this vaccine we talk about, or we are talking about, is with us in our routine program, meaning the day-to-day vaccination activities we do in the hospitals In the clinics and in the health center, at the health post, at outreach site, this vaccine is available. Then after November 21, the vaccine will still be in the healthcare facility. But at that time, we stick to what we call the routine vaccination age for this vaccine. And that goes only for 9 years to 14 years for our routine activities. But for this campaign, we've seen data, we've seen numbers coming from the counties, we've seen numbers coming from the health facility. The number of girls we're supposed to vaccinate each year, we are not reaching there as a country. That is why we are stepping up in this campaign to the upper age. That's where the MAC comes in, multi-age cohort. Those girls that have been missing this vaccine since we introduced 2019 till now, we think some of them are in the age 19 or 18, 17, 16. This is a chance for what they missed in the routine schedule for them to come and be vaccinated. And if you got vaccinated before, I hope my colleague can clear that. It is a chance to increase your level of protection against this notorious guys we call the human papilloma virus.
And just to add to what is doing, you said, it is important. Yeah, even though we say before sexual intercourse is best, but this time going up to 18 years old. So we are hoping that by 18 they are not sexually active. But just in case, the number and frequency of sexual intercourse is what matters. So the girl who is 25, girl who is 17, 18, obviously know that that girl who is 25, has been exposed many times. So it's important to capture them. And like they said, we are going to the 15 countries. This is actually preventable, as I said in the onset. So the target at the WHO requirement to eliminate this cervical cancer, to take the burden off us, what the preventive people are doing, is to make sure that we vaccinate at least 90% of our girls in that age group. And then about 70% of women who have passed that age group, be screened, come for screening. Every woman needs to be screened, whether you're sick or not. You need to come for screening. We have nurses that we train, we have clinicians, women clinicians that look at the service. Then at least 90% of our population needs to be treated. So when you screen and they see the lesion or they see something on the service, they need to treat that to prevent the cancer. So it is 90, 70, 90% of population, girls in that population vaccinated, 70% of them screened at least by age 35, and then again by age 45. And then 90% of them, actually, those that have lesion or the disease, be treated. And that way, we can eliminate cervical cancer. The WHO is telling us that if we can reach that target by 2030, it means in 2120, about 100 years from now, we will have saved at least 62 million cervical cancer deaths worldwide, and most of the deaths are in developing countries, in the poor countries. So we'll be saving 62 million people or girls in the next 100 years. It means we'll be saving the population, because women are the population. They give birth to us.
What are those facilities you'll be visiting in terms of the vaccination process? Two questions in one. And after you've gone to these facilities, how will the vaccination be done? How many doses will you be giving to candidates?
The boss is here.
So let me speak to that. Actually, we have a strategy on how we intend to get our drugs. So let's speak about the strategy, then we'll talk about the doses. So with the strategies, we will be visiting communities. We will also be visiting schools, because if you look, most of our girls of that age, they are in school. So we'll be visiting schools as well. We'll deploy vaccination team in every health facility and other communities. So it's like, for example, if you were placed in a community today, when you cover up the total number of persons you need, then you move to the next community. So we'll have the team, we call it a mobile team. They will be moving. And we'll also have a team that will strictly be in the health facilities, for those health facilities that are offering immunization activities. So it's not all of the health facilities, but those ones that are offering immunization activities. Because in those health facilities, we have our coaching equipment where we can save the vaccine until it reaches the beneficiary. So they will also be there. And we'll also be visiting town to town, the schools, the health facility, like I said. Those are strategies that we use. People will be to marketplaces, will be to transit center, will be at bordering points. So everywhere where we think we are able to get our age group, the 9 to 18 years old girls, is where we're going to place the team. And for the vaccine, we have just one dose.
Okay.
So the one dose is enough to provide protection up to 95% efficacy. So once the child receive or the girl receive one dose, yes, she will be protected against the vaccine. The only place we differ a little bit, or where we change a little bit, for people who are immunocompromised.
What does it mean?
Yeah, I'm coming down to meaning that people who have
Other
maybe
conditions for which their own fighting
Conditions.
system cannot stand on its own.
yeah, maybe condition where your system can stand alone. So for instance, if you got nutrition problem, like you're not eating the adequate food, your system break down, they are immunocompromised. Maybe people who have HIV and AIDS, for example, maybe people who got TB. So there are certain conditions that can compromise your system. Remember Macaulay talked about even tobacco smoking. Those one can also compromise the system as well. They expose you. So for those people, we give them 2 doses. But whenever we give the dose this time around, then we will give you 6 months apart for you to return for the second dose. So we have the vaccine in our routine service. After the campaign, that we are speaking campaign, there will still be vaccinator at the various health facilities who will be giving the HPV vaccine for this age group from 9 to 14 years as well. So that's how.
No,
So
she
I
also
like-
asked about where people can go to access the
Yeah, I think she said it, and she said it with a summary that the strategy we are deploying or we're using in this campaign comes at November 17 to 21 is one we call fixed site strategy. By fixed, it means the current healthcare facility that are giving vaccination services, the teams will be there for the course of that vaccine campaign. Then aside from the fixed site, we have temporary fixed sites. Those are not the regular vaccination posts or sites. The communal points, like you go on a school campus, you go to a church compound, you go to the mosque where the Jama'ah is going on to be able to get a grasp of those girls. We say it's a temporary fixed site. They are there for hours or for a day or 2, then they move on to another point. Then they turn to that, which is also part of the temporary site strategy, are what we call the mobile teams. They are moving from point to point, making sure that no girl is left behind in the strategy. And with that strategy explained, it means this is a huge tax on the Ministry of Health. Remember, the community health does not control them. The schools are not under our control. The reproductive health area, where we call Friendly Center for Girls, they might belong to gender, but this is where we are making a call to action, collaboration and partnership. We are working currently with the Ministry of Education to map out the schools and even do a listing of the girls in this target age group so that we can just go with ease to deliver. And even working with schools say it's still not enough. Some parents, you need to get their consent before their girl child or children get vaccinated. So through the school connection, we also are working with the Parent Teacher Association, what we call the PTAs, the health clubs, and then applying us also on the collaboration with Gender Ministry. We also are working with our gender coordinator in the county to use their services available for adolescent girls for us to be able to vaccinate the people. Then at the communal point, we are working to penetrate or work with community leadership, especially using the structure set up by the Ministry of Internal Affairs, working with chiefs, working with paramount chiefs, the rest of the other structures are there. So it's a huge setup that we are working with all stakeholders across the country to make sure that Liberia comes out beginning on November 17, and by the 21st, we hope we can reach the 90% as described by our doctor.
I like
and
that.
then we can do the prevention more and more.
And you know, the myth in Liberia keeps growing when these initiatives are about to undergo implementation. A lot of people will say different things, especially from the rural parts of our country. Uh, People will be asking themselves as to whether this vaccine will cause infertility, whether, or even if it doesn't cause infertility, whether it will cause women to get pregnant as well.
Yeah, so let me speak to that. Firstly, I can say the vaccine is safe and is effective. By taking the vaccine to reduce the case load for him, because he's doing screening. So if he screens and you see a number of people not coming down with the condition, means that the vaccine is working besides the natural immunity. So for infertility, what we say it can make people can born. People can born. The vaccine is not responsible to make people not to born. At the same time, the vaccine doesn't also prevent pregnancy. When you think that if you take the vaccine you will not get pregnant, no. It is not the vaccine that will make you not to get pregnant. When you're not doing men bending, you will not get pregnant. We know that men can pregnant women. So the vaccine doesn't pregnant people.
So just quickly to add, I think my doctor is motoring, he wants to come here also. I think the issue of myth that we are encountering in our services as a vaccine program for the country, the more come from the urban area than the rural area. In fact, in the counties, whenever there is an intervention, they wait for their children that are in Morocco and say, oh, Ministry of Health is coming to do this thing. That child will say, yeah, you go ahead, we know about it. Yes. Or somebody will place a call and say, let me check. So most of our problem with, hesitancy to vaccination at times, which is not great for Liberia, the myth you talk about. At one point they said vaccine can make them pregnant, and another time they said vaccine can make them not to get pregnant. So who's fooling who? The thing is that while we are sitting on this panel to ensure that vaccines that come in country, they are safe, they are potent, that is, they are able to produce the protection we want for the human body, and by reason of it being safe, we rely on the WHO restriction of going through the industry that are producing vaccines that are considered credible. More to that, we have our own system as a government that we call the Medical and Health Regulatory Authority, the LMHRA. They are there to do licensure of our vaccine. So until they give license, that vaccine will not cross the border into Liberia.
Yeah, Doc.
Yeah, and just to add on what they said, they were very detailed. If you go into the hospital and you see the cases, most times cervical cancer, we say it takes about 10 to 15 years. So probably if a starts sexual debut at 18 or 20, you expect to start seeing cancer from 30 and above. But we see it as low as 25, 24. And they come very late. They come very late. Something that we can do very little about. We'll talk about treatment. So it's good that we are breaking this barrier, like he said. Yeah? The issue of uptake, break the barrier, because most of our cases are even coming from the rural area. So that's the reason why we are here. And thank God, the Ministry of Health, the preventive team is doing very well, so that we can understand this. If you don't, if a child or girl come down with cervical cancer, I mean, it can be very, very depressing. And we as the healthcare worker, when we see them, and most times it's just palliative, counseling, supporting them. So we don't want to reach that level. So that's why, we want to make sure that, our pastors, our imam, the school people, the parents, they should take initiative so as to save the next generation.
Dr. Smith, you currently conducting screenings for cervical cancer, and you mentioned that when you see a lesion, you go ahead and treat that lesion. What are the different treatment options you have?
Okay, so let me take you back a little. Yes, we are doing screening, and so you vaccinate girls. Then the next strategy is you screen. It's good that we are hoping to go more than 90%, as we say. Then you screen those girls who are sexually active. So we are now screening above 20, 21, 22. There are tests that we're using. The test we use to screen is to look at the cervix. We have our midwife and our nurses, uncle nurses that are trained. They will look at the service, they apply vinegar, call it acetic acid, via. And just by doing that, you can see when there's lesion or the service is free. There's also another screening, which is the recommended screening, HPV DNA. That is ongoing. In a major facility in Mortuary County, where they screen and they take sample and they go and check to see who have this HPV. Because like we said, we don't want people to have HPV so that they can develop cervical cancer. So that screening is also ongoing. And then we have our routine screening we call pap smear. Every woman that goes to the clinic, whether sick or not, we encourage them to do pap smear. Women are supposed to screen every 3 to 5 years, whether you're sick or not. So that's what we do. Now, when you are screened, and the nice notice that you have a lesion, you have something on the cervix that is not normal, then they will refer you now to the doctor. It is where you will come and say, okay, you have to see the oncologist, the gynecologist. And then you will come in, and then if we see that lesion, we're going to do something called colposcopy. It's almost like a TV. We look at it, magnify it, and see what it is. And then we say, oh, this, as we say, cancer don't just come. It comes with lesion, pre-cancerous. Then we go and remove it. So the question you ask is, we can remove it by burning it. We call ablation. We have it in our facility. We can also remove it by excising it, by cutting it out, which is very good. And then we send it to the pathologist. We call it a lip. Then again, we can, if that lesion is cancerous, but it's very small, probably less than 2 centimeters, because it takes time to grow. Yes, we can do colonization, something that will go in. If that person still desires to have a wound, we can just remove the cervix and make sure we have a clear negative margin. Okay. And then that patient can go. So those are the things we do, and we have started it, in our facility at GFK. It is currently ongoing, which is commendable. Yes, and again, if we also notice that there is a lesion that is there, visible lesion, that is maybe more than 2 centimeters, something that we suspect as being gross cancerous, we take just small of it. We call it biopsy. We take a little, we send it to the pathologist, and then we wait for the results. The pathologist will give us the result and tell us, yes, this is cancer or this is not cancer. We tell the type of cervical cancer. Then based on that, we have treatment options. The treatment option for cervical cancer is radiation and chemotherapy. Radiation and chemotherapy. Unfortunately for us in Liberia, we don't have radiation for cervical cancer. We don't have. But we have chemotherapy.
So that's the only option we have.
That's the only option. And then we also have surgery. So depending on the stage, and the cancer will come small, we'll start from stage 1. So if you come soon, that's why this whole campaign is very important, If you come soon and we notice that it's just stage 1, then it's where I come in. With my colleague.
Is there a possibility of reoccurrence?
We go and operate. So that's where it is operable. And that operation is done by the gynecologist, not just any gynecologist. Because it's a very big operation. But we remove the lymph and everything, then we send it to the pathologist and they will check, they say, okay, everything is removed. All the nodes are negative, the margin are negative, then that person is free. But if it is above stage 1, that is, if it's stage 2 and above, then it means that you need to do radiation and chemotherapy. But the good thing is they have broken ground now for the radiation suit at GFK quite recently, and we are hoping and praying that we will not be encouraging our patients now to go outside to Ghana or to Nigeria for radiation. But we don't want to reach that level. So when we vaccinate, we will not reach there. We will reach our target.
I like how the doctor concluded all he explained from the clinical landscape. But what is like the blind spot to the discussion so far of all the procedures you outlined? The cross margin has not been mentioned. And this is where vaccination becomes a gold standard. Instead of counting years to begin screening, instead of waiting to do clinical visitation, transportation, cost for registration, laboratory costs, or let's say investigation costs, treatment costs, that can be short circuit, it can be bypassed if only now at a young age if we bring our girls to be vaccinated. Then when they go for screening in the upper age, they will not find anything. So now is the time that Liberia listen to us and let the community get our buy-in, and also the parents to support all the stakeholders, all the line ministry, agency, and concessional government to support the Ministry of Health. Let the girls come early for vaccination.
Okay, so we're about to open the phone lines, and you heard, if you just joined us, you're listening to Roads Way to Health, an hour-long program brought to you by the Ministry of Health. We're in talks this morning with three health experts. This is Elizabeth Dole, Dr. Smith, and that of Mr. Newey, educating and providing valuable insights on the upcoming HPV multi-age cohort vaccination campaign, and also other important information that concerns you about cervical cancer. To be a part of this conversation this morning, you can call us on 0775-677-376, 0775-677-376, or 0880-514-096, 0880-514-096 are the numbers to call. Call us this morning and be a part of this conversation. You can ask questions, you can also contribute. So we have our first caller. Good morning. Your name and where do you join us from?
I'm patient Robert calling from Louisiana.
Go ahead, patient.
Yeah, I want to know what are the tell me is free?
The vaccine?
Yeah.
Oh, okay. Tata will respond to that. Good morning.
Yes, good morning.
Your name and where do you join us from?
I have a few questions to ask, please.
Go ahead.
Yeah, I want to know, is this program being sponsored by the Gates Foundation? And secondly, what are the statistics?
You said? Hello?
I think we lost him.
No, he's off the line.
Good morning. Good morning.
Good morning. Yeah, good morning.
Your name and where do you join us from?
Yeah, this is Bill Moore calling from Tristan Gates.
Go ahead.
Yeah, I got a few questions to ask. The vaccine, is it only for the age group 9 to 18? If yes, what about those girls that are under 18 but they are actively having sex and some have children? Can the vaccine work for those kind of girls?
Okay.
Then two, the bigger ones that are going for the checking, I would like to know which specific area that you will be doing this checking. Three, if a man is a carrier of this virus, is there any way that you can detect? For example, a man is carrying it. You said a man who is a carrier cannot be affected by the virus, but can affect the girl.
All right.
Okay.
Thank you. They got you. Morning.
Morning, Melvin. Good morning. My name is Noah Zawu Gibson.
Go ahead, Noah.
Yeah, why it's true I'm not the spokesperson for the guest, but I think the caller inquiry had already been addressed by the folks there at the health ministry. They said the vaccine is from 9 to 18. So that means if you're under 18, you can take it. So I don't think. And then before I leave the line, as the Deputy Managing Director for Operational NTA, I can simply confirm to our public that the 35 buses are just landed at the National Port Authority. And the first 10 have been discharged on the ship already. And we're expecting 20 additional ones with 5 cargo trucks. But the 35 that have just arrived are all 60-seater buses. So yes, the buses are now in the country. I can confirm this.
Okay.
Noah, thank you so much.
Thank you.
I thought you were coming here also for the
Good
Yeah,
morning.
you see, Noah, anyway.
He has to support our transport.
Yeah,
effort.
so Noah, the people are saying you use their platform, the Ministry of Health platform. So you will have to give 2 of the buses to them for that campaign, yeah? So
Yeah.
That's a good one.
Yes, please.
go ahead.
Yeah, I'm the Ontoa and I'm calling from Zulu Whiskey on Toa Street.
Go ahead from Grand there.
Good. I want to know if the 500 question, because I listened to one of the panelists said that they
up to 500. The 500,000.
500,000.
560,000.
500,000. The 500,000 is a iron vaccine.
You said iron vaccine?
No, whether it is
annual.
a target
Oh.
for the whole year.
Oh, okay.
1,000 girls that will be vaccinated. Let me make it clear because
We get it.
I look at the age limit there between 9 to 18. Okay, to be not socially active or from 19 to 25 to be sexually active. Now,
Okay.
our population says that the majority fall in that age range. So the 500,000 figure there is too little. That's one. Two, almost one of the speaker was saying, one of the caller was saying something regarding the carer. The men are the carer. The young boys are the carer. Now, is there any way too that they can be vaccinated so as to prevent the girls from encountering this?
All right. Thank you. Thank you, Deacon. We don't have time. Time is already out, so we just enjoy. We go back to the guests. We just respond quickly, maybe in the next 3 minutes. Then we can let them. Yeah.
So,
yeah, go ahead.
so I can address some of the questions and my colleague here can add up. So the first question is whether the vaccine is free. The vaccine is absolutely free. We are not paying for vaccine. Any vaccinator who charges money for taking the vaccine, please try to report it to us because the vaccine is free. That's the first answer. The second one they asked was that 19 to 18 years, 9 to 18 years rather. The 9 to 18 years we say they are the ones that we are targeting. So people who are below 9 years, that is 8 years and downward, we are not vaccinating them. We are only vaccinating 9 years to 18 years. People who are 19 years old are also not part of the vaccination process. Because we feel that when a girl passes that age, where they are around 19 to 20, like Dad was saying, they are involved in sexual activity. Even though in other countries, they vaccinate up to 25 years old. But for us, Liberia, we are only vaccinating up to 19 years. And it is because the time the vaccine was introduced in 2019, we feel that people missed out that vaccine. And so we still want to grasp the group of people that were left behind, or girls that were left behind.
Okay.
And probably to add to that age group, because someone said some girls below 18 are already having kids and whatever. Yes, so they still have to be vaccinated. Like we said, the more sexual intercourse you have, the more the vaccine stay, the more it causes problem. So there are strains of HPV. So if you are below 18, we are hoping that you have not encountered a lot of strains, with a few sexual intercourse you have had. So your rate of being protected is very, very high as compared to if you are more than 18, 19, 20. So that is important. So vaccinate all. And those who are, he said, how about those who are above 18 to 19? You come for screening. That's why you come and screen for us to be following you up very closely.
So just your party comments in 15 seconds. Then we'll come to you. You close up. We'll come to Mrs. Smith and Mrs. Edo. Then she will just part us maybe 10 seconds. Then we'll conclude with you, sir. So Doc, 10 seconds quickly.
Yeah, thank you so much, and I want to thank the Ministry of Health for this campaign that is coming. The concerns that have to do with screening, in my parting comment, I will address the one I have to do is the screening is ongoing now in our major hospital, GFK, Redemption, JDJ. Someone asked, you can take your relative there for screening, take your girl there for screening, and then the next thing is cervical cancer is life-threatening. It is the #1 cause of female cancer death in Liberia. And so it is important that we take the bull by the horn, we vaccinate our children so as to avoid this catastrophe.
Okay. So, Madam Doe, we don't have time because we
Yeah,
we
just-
need to go up Capitol Hill for the outside broadcasting.
So
It's
just
true. Let me just clear the issue of
Yes.
the target. So we expect, we say we vaccinate up to 90%, and the information I give is that 90% coverage. But we expect to reach girls up to 700,000 within our cohort for the person who asked that question. The next thing is that pregnant women do not take this vaccine. We don't give it to pregnant women. We also don't give it to people who have reacted to it if they took it before, and people who actually are over sick, they are really sick. So I want to urge all of our ministries, our traditional leaders, our mosques and imams and pastors, and our education ministry in the general, to encourage the girls to take the vaccine.
Thank you.
Okay.
Yeah.
Yeah,
So
thank you.
Yeah.
That being the last hope and the last for now. So somebody asked about the sponsorship or the program, and we are getting the support from the Vaccine Alliance, a group that is called Global Alliance for Vaccine Immunization, Gavi for short. They provide the support to the ministry directly, and through the Total Health Access Initiative, we are running this campaign. And to just close off, we say, like the kindergarten song we sang, go and tell it on the mountain, over the hills and everywhere. We are calling the pastors. As you go to the pulpit, tell your congregation. As you go to the Jama and the imams, tell your congregation. The teachers, tell the classroom. The parents, tell your family. And the rest of the population of Liberia, wherever you find yourself, get ready for November 17 to 2021. We are bringing HPV closer and closer with vaccination activity in the country, in the 15 counties, and in all of our health districts. Thank you.
Thank you. Angel, yes.
Yeah, so you heard our guest, cervical cancer is life-threatening, so prevention is very better than cure. And many thanks to our guests, Dr. Smith, Mr. Murray, and Mrs. Doe for sharing such valuable insights this morning. We have been your host, Angela Noah, and
Melvin Stewart.
Augustine Gaima has been here. Until next Tuesday, have a good day.
Bye.